the patient doesn't want compliance, doesn't want to show compliance, then you have to think about lingual fix then. Like in this case, this is just a little piece of cake, again, piece of cake. But then again, this is a, well, in a sense, I have to tell you, this is a compensation, a lot of compensation. Have a look at the forward inclination of the molars. And have a look at the forward inclination of the upper molar. If you want to correct this, then you have to distalize the molar much more than you think you need. Have a look at the molar relationship immediately after leveling alignment. Immediately after leveling alignment, you have a lot of exacerbation of the class 3 molar relationship, especially on the right side, like you see. And that happens just because of an AP decompensation of the first molar, because I used the continuous arch wire, just like that, and then subsequently you will need a lot of retraction of the lower incisor. And this takes a little bit of a manipulation, first on the molar segment, second on the lower incisor segment. What is that? Just because you don't want to tip the lower incisor backward, what you need is, this was supposed to be simple case, but it's never easy because a lower incisor has to be retracted by bodily movement. Then how do we gain bodily movement on the lower incisor using lingual brace? Well, as a matter of fact, she's happy, and we gained something like this. It looks like there was a little bit of a functional shift, but the way how lower incisor has moved was purely bodily movement. And then, just because we don't want to tilt the lower incisor backward, if you go back, this seems to be like regular 22 slot, but I use a lot of a torque arch wire for lower incisors, which has a 20 degrees torque. Otherwise, you will end up with a lingual tipping of the lower incisor. So this one takes a little bit of a lot of a manipulation, but like I told you, when it comes to aligner biomechanics, just because even without your knowledge, just because the aligner wraps around the lingual side and labial side, you don't seem to pay a lot of attention to torque correction. This is something I'm going to talk about later on. So this was a case of a lingual fixed appliance. Again, issue number one, when it comes to aligner, you can be encouraged to use a lot of aligner as long as you are rich, because it takes a lot of money. Every time, every case will take you $2,000 of money. But that's one thing, and second thing is you need a lot of patient compliance. Now, let's have a look at the open bite. A lot of open bite cases out there. This is a combined cross bite and open bite, one side. As a matter of fact, open bite, aligner has a strength and advantage in open bite correction. It was a very, very terrible homework for us for more than a decade, but ever since we started to intrude the molar, it's not a big deal anymore. But you don't seem to use a mini screw when it comes to open bite, when the open bite is combined with the spacing. Let's think about the biomechanics. I don't think we can just give it a try. Let's think about biomechanics. What do we need in this particular case? She's a 16-year-old girl. She has posterior crossbite. So one problem is the transverse. What is the second problem is the open bite. If you are a very big user of the mini screw or mini plate, you may want to intrude the molar, but I don't think you will have to use the mini screw because that has a spacing. If we close the gap by pulling the incisor backward, open bite will be closed by itself. It doesn't take a lot of biomechanics or anything. What do we call it? We call it drawbridge effect. Okay? We call it drawbridge effect. if we drag the incisors backward, the vertical dimension will increase, the incisor edge will come down, so open bite will be closed. So we are not worried about open bite correction, especially this thing is combined with spacing. What concerns me was the transverse correction. I'm wondering if we can correct the posture crossbite only with aligner. I'm going to talk about it right after this case. Just because we know it's not going to be easy to correct the transverse problem only with the aligner, and we use the RPE first. And then, after using the RPE, you can use the aligner. When it comes to transverse problem in the first molar area, I would strongly advise you to use a RPE before using the aligner, because aligner is not able to expand the arch in the back side of the maxilla. Do you understand why? What did I tell you? This is an extended ribbon arch that has a horseshoe shape. Think about ribbon arch extended from 7 to 7. And imagine if you can ever expand the first molar and second molar area with the ribbon arch. What did I say? Ribbon arch has a flexibility transversely. We need a heavy constant force to be able to expand the arch, especially in the back side. Which is first molar and second molar area. Then we already know it's not going to be easy to expand the first and second molar area only with the aligner. So we use the RPE, just like that. And then the rest of the things, using the aligner, using the attachment. Still, we don't know what kind of attachment we have to use. It's a lot of attachment here and there. We're aligning. By the way, what is that? What is the metal ball sticking out of it? This is the nose ring or something. That has nothing to do with the anchor. No, it's just her hobby to have something between the two nodes. That has nothing to do with the orthodontics. We are focusing on the only on the attachment. Also have a look at the tongue piercing over here. Beautiful. That has nothing to do with the orthodontics. That has nothing to do with our anchorage preparation. Again, oh my God, this is a lot of attachment in the middle of the treatment. And I'm still wondering why we needed that many. Diverse attachment just like that. So if you look at this, you know you have to extrude premolar. Extrude canine or premolars, extrusion. And we are wondering if this kind of attachment will definitely help us to extrude the teeth, extrude the premolar. Are you sure about that? Are you sure about that? Does it have to be, let me ask you one question, does it have to be this way? We know that we're gonna extrude the first premolar just like this. But I'm wondering if it has to be this way or the other way around. What do you think? Does it have to be just like that? Or does it have to be the other way around with a little bit stiff inclination on the gingival side? Which one do you think is better? The Align Tech comes up with this idea. You have to put your attachment. Well, this is not an Invisalign case. This is a Seraphim case, which is a Korean brand. They use the same sets of attachment. And then we know we have to align the lateral incisor. We have to extrude the lower premolar. Let's have a look. This one has a stiffness on the gingival side. This one has a stiff area on the occlusal side. There's no consistency. There's no consistency. Just we are advised to put an attachment here and there according to the clean check. And let me ask you one thing. Who designs, you know? Do you know who actually designs all these attachments? Do you know? You are professional orthodontists, all of you in the room. Do you know who actually designs all the attachments? Give me an answer. This is someone who knows nothing about orthodontics, someone who works in Costa Rica. You know what I mean? Is that correct? Is that correct? They design all the attachment on your behalf, and you are like following. Oh my God, I have to put an attachment just like that. That's the reality we are in. That's the reality we are in. It's someone you don't know. You talk over the monitor. Please do this thing, do that, do that. Through the monitor using the kun chat. This is a Costa Rican word. Costa Rican word. And you know what Costa Rican laboratory technician? He didn't even, who knows nothing about the occlusion. Nothing about tooth. He or she may have majored English literature or Vietnamese language or something. Who knows nothing about dentistry. That's the reality we are in. No one explains why this has to be shaped in this way, the other way. And this is grasped by the plastic material, whether it's a rectangle, whether it's triangular, whether it's ovoid. They are all, and this is similar to the continuous arch biomechanics that the person has extensively described. And this is, there's no point. Alright, midline is almost constant. Midline is almost constant. Do you like the final occlusion? I don't like it. Why? Have a look at the molar relationship on the right side. It's edge to edge bite. Well, you can say, if you go to Invisalign seminar, the Invisalign speakers will say, no, this is not a Invisalign case. As a matter of fact, this is some Seraphim case. Not bad, but the transverse relationship, especially on the right side, is not really complete. Like I told you, we use RPE as a first step of the treatment. If we had used a liner from the very first place without RPE, it would have been worse than this. You understand? Why? Because a liner has a weakness in transverse correction. Where? Especially in the back side of the arch. Let me explain why. I'm gasping. And just because we close the open bite, it has nothing to do with the molar intrusion. It has nothing to do with the molar intrusion. The mandible plane did not change at all. The open bite was closed. Why? Because we closed the gap by pulling the incisor backward using the interdental space. And this is a typical example of a drawbridge effect. What is drawbridge effect? Just like that. So, if you notice at your open bite with the spacing, not a big deal. You can really use the aligner from the first place without worrying about molar intrusion or something. But transverse problem was not very well addressed